Okay. Let's get started, please. All right, so just to let you know, so good job on the exams. I will be returning them for you to review. I do like you to see where you went wrong. So you will see your actual exams. What other instructors do is up to them, but I will return. Often the reason that instructors don't return exams is because people get hung up over half marks or whatever. I want you to know, one, that I can add, so if I made a mistake, you can check my adding to make sure your paper adds up. And two, I want you to know what you did well, as well as what you can improve on. And for me, the only way I can help you with that is for you to actually see that. At this point, it looks like it will probably be Thursday at lunchtime. So I'll make a half an hour for you to come. Please, no cell phones, so leave it in your pocket. You're welcome to come. You can talk to each other. I will ask you to stay seated. You don't write anything down. When you leave, you can write anything down you want. I don't really care, but the whole idea is for you to see it and get some feedback. All right? If after that you want to come talk to me about anything, absolutely, I'd be happy to do that. But until you actually see your exam, I'm going to hold off on meeting with anyone except who I need to meet with this week. Because hopefully when you see the exam, I've actually written in all the answers that if you got them wrong, so hopefully it will be very clear. All right, so we're on to our second joint of the lower extremity. Oh my goodness. I'm not going to tell you that we're now 2+ weeks to finals, 2.5 weeks. Yeah. All of a sudden that hit me on the weekend when I was marking, thinking I should be writing the final exam. All right, next weekend. So we have done our lower quadrant scan this time. Once again, we don't know the specific tests. Lumbar spine clearing test we'll learn next term. The SI joint we'll learn next fall. The knee combined movements we'll learn next term. So we know to do any joint that can refer to the hip, so SI, lumbar spine, and knee. And that has led us, these were clear, so we have to make that assumption at this point. In your junior placement, you'll be able to clear everything but the SI, and you can always ask your CI, just say, we have not taken the SI joint yet. Can you please tell me how I can clear the SI? And now I'm ready to begin my detailed hip assessment. So what do we need to know? Well, certainly age is important. So some of you may be working in pediatrics, working with children, working with infants. The good news is this stands for congenital hip dysplasia or dislocation. Dysplasia just means failure to develop. So congenital hip dislocation or dysplasia. Congenital hip displacement you are not likely to see now with the infants you're working with because they are screened at birth. What you are going to see now, though, is all the baby boomers who this was not picked up with at birth, who are now needing total hip replacements because of the OA changes that have resulted from failure to pick this up in infancy. So certainly this is not one that you are going to see, except perhaps in third world countries. This is screened in most Western countries and treated right at birth should there be a problem. Also, we need to understand that, a patient complaining of loss of range, if they are in their 80s, that is normal. If they're in their teens, that is not normal. And the conditions that we're going to talk to, so specifically, if somebody is presenting with a limp, and especially, so I'll write this out for you, especially around the age of 6, this is the most common pathology that causes it. So it's called leg, Kathy, Perthes, 3 surgeons, orthopods, leg, Kathy, Perthes disease. So it is the most common cause of a painful limp in a child in this range. Sort of the peak age seems to be around 6. So first off, what is leg, Kathy, Perthes disease? it is thought to be a change. So what happens is a change in the blood flow comes from the circumflex to more the obturator artery with growth. So the circumflex normally in childhood supplies the head, and then it transitions to the obturator, coming with the transverse acetabular ligament. If the blood flow is affected, what happens is we end up with one, magnifying of the head. The Latin term for hip is coxa, and it magnifies or makes it bigger, so it's called coxa magna. So a bigger than normal head. Well, let me see. So there's the head. Here's the acetabulum. Does that head fit in that acetabulum? No. The other thing that happens when you lose and alter the blood supply to the head, you end up with not only a bigger femoral head, but you end up with a flatter femoral head. We call that coxa, hip, plana, P-L-A-N-A, coxa plana. So it's bigger and it's flatter. And so the limp is because the head is not really articulating well with the acetabulum. So a child who's limping and complaining of hip pain, this is one of the things that we're automatically thinking, could this be? And we're trying to refute it. To refute it, you need x-rays. In the elderly, and the question always is, could a patient who has fracture walk into your clinic? And the answer is yes. So certainly elderly females, there's two reasons for that. One, right now in epidemiology worldwide, there are more females than males in the elderly. Okay, it's changing, but it's still more females. And on top of that, because of the changes in estrogen level with postmenopause, osteoporosis predisposes women to more fractures. The most common cause of hip fracture is not actually a fall, it's a trip, so a twist, catching your foot on a rug or on a pet, cat or dog. They move unexpectedly in front of you, and they twist. The twist causes a fracture, and they fall down because of pain. And then the fall then further dislodges the fracture. But the actual fracture often happens before they ever hit the ground. Hitting the ground just magnifies the fracture. So somebody coming in having a, I tripped over the cat, I tripped over the rug, and I've had a sore hip ever since. This is something we need to be ruling out. It can be an elderly male as well. There's often a history of trauma, but they may say, all I did was twist it. I didn't fall down. I was able to catch myself. So a lot of people would rule out fracture. No, it's still very possible. So this is, this is a fracture. So this is where the head has in fact fractured through. So you can see there is some slippage, so there will be shortening of the affected leg. So would you be able to see that in the position that they're lying in? So past medical history is so important when we look at all these other childhood diseases. This one is one I haven't talked about. This is one that is on the rise in your age, okay? This is what it is. So this is a young child. This is not a fracture. This is actually the growth plate. And in this case, the cap, so slipped, capital, so it's the head of the femur, growth plate, epiphysis, has slipped. Please understand that this is the cause of a painful limp in adolescence, particularly adolescent male, particularly skeletally immature adolescent male. And what do you think would add to slippage of the head? What physical feature would cause more slippage, more shear through the hip? Thank you. Absolutely. Obesity. And with childhood obesity on the rise, we're actually seeing more and more of slipped capital femoral epiphysis. So this, although congenital hip dysplasia is on the decline, Legg-Calvé-Perthes disease is on the decline. Slip capital femoral epiphysis is on the rise because of childhood obesity. The other thing you need to know is, one would think that the greater the slip, the more pain the patient would have. Does that make sense logically? Logically? Bless you. Logically it makes sense, but in truth, you can have a full slip and have it pain-free, because this is a slow slip over time. So the degree of slip really doesn't relate necessarily to the degree of pain. All right, so this would be a young adolescent male, limping, pain, no insidious onset, so it's often over time. There's rarely a trauma involved, and presenting now to your clinic. So you need to prove it's not this. All right, again, we're going to be looking at the mechanism of injury. What is the position of the hip at the time of impact? If they can describe it to you, and in this day and age of videos and cell phones, often there is video available. Okay. I couldn't believe that somebody caught, was anyone watching the All-Star game on the Celebrity All-Star game? And Chris Pronger caught Justin Bieber along the boards and smushed his face in and gave him a face plant. Sorry. And had a big smile on his face when he did it. Sorry, I was... So, I mean, the camera just happened to be, it was an Associated Press cameraman who caught them in the corner right at the moment, and with the smile on his face. It was quite amazing that you would capture that at that particular moment. All right. So, certainly you may have help having your hip taken beyond normal physiological range. So, certainly that, so martial arts, certainly hip can be an injury. This was my repetitive strain Elvis pelvic thrust. Sorry. You guys, I was marking all weekend, so I was trying to make it funny for this morning. I thought Elvis was pretty funny from repetitive strain injury, but that's okay. I'll go back to sleep. I was better there. All right. So when we're talking about hip, we do want to know if it's a hip, one of the things that's most important with the hip is where is the pain. And this is a true story. I think I told you this was my patient who came to me with the hip really likes anteromedial knee. And he was convinced, remember I told you it's the knee. And I kept looking at his hip and he went, my knee hurts. And I said, no, I know that. I just need to go through. My knee hurts, because I kept around his hip. So do you remember one of the things I said before you go to the detailed hip, you would clear other joints? I couldn't convince him that his hip was not the cause of his knee pain. So my way of convincing him was to try to clear the hip. Well, if you yourself know that the hip is the cause of the pain, you would never try and clear it because you would assess it. But I couldn't convince my patient. What happens when you try and clear the hip, so it puts the maximum amount of stress on the hip? What do you think happened to him? So I said, okay, so I'm not going to touch your knee, right? So you agree, I'm not bending your knee. I put him in what's called the hip quadrant, and guess where I peeled him off? The ceiling. And when he came down, he said, beep, that hurt. And I said, but that wasn't your knee, that was your hip. And then he sort of smiled, and then he said, maybe you do know what you're doing. And I thought, once in a while, maybe. So he had osteoarthritic change in his hip, and it was referring, he did not have hip pain. And he was very clear to that. And the only way I could prove it was to flare, and I did, I flared him miserably. I would never do that normally, but I could not convince him. So once I flared him and proved it was his hip, then I had him. I mean, he bought in totally. I could, as far as he was concerned, I walked on water. I lost that very quickly, but at least for that moment I did. So again, with this, and please understand that that is referred pain to the knee from the hip. No hip pain. So where did it start? Is it the same now? So my question was to him, did you ever have hip pain? Oh, and he was in construction work, and he said, holy, I've had every pain imaginable, but I can't tell you specifically the hip. So no, I'm sure everything at some point is hurt. And he said, have you ever done 14 hours of physical labor? No, not truthfully, probably not. So not at the level he was talking about. So I did appreciate that. But there probably was a history there where at some point there was hip pain. What can they do? So often patients with hip pain, the first thing they want to know is, are they going to be able to golf? And it's the rotation that they have troubles with. Okay, so it's the drive. So what is it that they're having troubles with? My golf swing is all off. You got to fix me. Okay, it's my hip. I can't, my handicap has gone up. You got to do something. Okay, so their priority is not the hip pain, it's their handicap and golf handicap, not their disability. So what is it that they do? Often in the hip, it is rotation or weight bearing. What do they do as a patient, or for the patient for comfort? Why do you suppose elderly love rocking chairs? What do rocking chairs do? They rock. What are you doing while you rock to all your joint mechanoreceptors? Stimulating them, which is inhibiting pain, absolutely. You may not remember, but maybe you have a little brother or sister. Did anybody ever have a little brother or sister who had colic? Okay. And what did your parents do? Rock them, constant, or drive them around in the car because of the motion. So the joint mechanoreceptors help, right? They activate and stimulate and decrease pain reception. So often the patient will tell you, especially the elderly, I rock. Okay? Or, my favorite is I use horse liniment. I'm like, horse? Real? Like, hey, horse? And they're like, yeah, the one they use on the horses. I got it from the vet. And the truth is, it actually was sold in the pharmacy. I found out afterwards. I was like, vet, horse, isn't that maybe a little bit more potent than for human? But it wasn't. So I actually asked the pharmacist about that one. All right, so what do they do? The other thing that's interesting with the hip is we get all sorts of snaps and pops. So first off, what can cause that? So we can have the iliopsoas muscle snapping over the anterior aspect of the acetabulum. We can have the iliofemoral ligament riding over the femoral head. That can give a snap. We can have a snap on the outside of the leg, which is a tight IT band. You can have a click or a locking in the hip, which we often associate with acetabular labral tears. So very same as the shoulder, clicking, locking, we think of in the shoulder as a labral tear. Somebody who's had a dislocation and who's describing, months or weeks later, they're hearing a click, deep click in their hip. So when you palpate, you can tell it's vibrating. It's not, you can actually palpate the tendon or the ligament. And loose bodies can also give rise to locking in the hip. Okay, sometimes painful locking. The loose body could be cartilaginous. The loose body can be osteocartilaginous, so both, or it can be bony if you start to get degenerative changes. So the hip is very much a noise maker. It often has these sounds associated with it. So particularly the snaps on the front of the hip, some of you may actually get it, those of you who are runners. Some of you may get the snapping of the IT band over the greater trochanter. That is also a very common repetitive strain injury. So again, what you want to know is, are there any particular movements that the patient is having troubles with? Often quads are inhibited with hip pain, and so often they describe difficulty getting up out of a chair, perhaps putting shoes and socks on that requires the control, especially doing it in a squatting position. So is there any particular movement? And we're going to look at how to test all those. ADL, what is it that they do and what position? So if they're is it an active lifestyle? If they're a soccer player, what position? We know that soccer and hockey are particularly predisposed, and football, to groin injuries. So what is their sport? What is their position? How often do they play? So somebody playing every other day is certainly going to have more repetitive strain over time, and perhaps trauma related to fatigue. So what can't they do? So they're no longer able to play soccer. They're no longer able to cycle. They're no longer able to play competitive hockey. What is it they can't do? So this is hip contusion, hip pointer. So this is a soccer injury from a hard tackle. So you can see there's ecchymosis or bleeding into the soft tissue. It's quite painful. They're not really happy with even shorts over top because it's that uncomfortable. So with the hip, is there any discoloration? Often you won't see swelling so much with the hip because of the muscle bulk around the hip. Certainly deformities, you might see the shortening of the leg if there was a fracture. You might see the hip flexed, externally rotated with the head of the femur. If somebody were able to dislocate and limp into your clinic with the head of the femur sitting in the anterior groin. If they had dislocated posteriorly, they would be in the opposite position with shortening of the leg, internal rotation. In this case, you would see that the buttock would be more prominent. Please, I don't expect you to know that now. We'll talk more about those specific pathologies next term. I just want to be knowing what you're looking for. So what deformities might we see? So leg shortening, abnormal contour at the front of the hip or the back of the hip is what's important. Posturing is, again, the inability. So it's putting the position. If they have dislocated and not relocated, they will position or posture themselves, and this is the position of an anterior dislocation. This is the posture of a posterior dislocation. So hip flexed, internally rotated, 80 depth. The force is usually through the knee to drive the hip out the backside. So again, also with the increased lumbar lordosis, we need to be looking at, could that be related to tight hip flexors? In which case the lordosis would be high. Why would the lordosis be high if you have tight hip flexors? What attaches to the upper lumbar spine? Transverse process anteriorly. Good, iliopsoas. So iliopsoas, if it is tight, can cause anterior translation of the vertebrae, the upper vertebrae, which will give you an increased lumbar lordosis. Hamstrings, bless you, can also create rotation in the pelvis. We are going to be looking at leg length. Now, normally, we should be looking at from ASIS to the lateral malleolus. Sometimes clinically, you'll see therapists measure from ASIS to medial malleoli. Please avoid that, because if you go over the quad's muscle mass, if you've got a difference in size, that will come across as an apparent leg length. The only way to measure a true leg length is full floor to ceiling, head to toe x-rays. And you wouldn't normally do that. So this is an apparent leg length, so you're comparing to the lateral malleoli. That avoids most of the bulk of the thigh and gives you more accurate readings. The next thing is we need to know is if there is a leg length discrepancy, is it in the femur length or is it in the tibial length? So if we're looking at the tibial length, then we look, this is the patient is lying down with knees bent, and we're looking for one knee being higher. So this is either the short leg or this is the long leg, depending on your measurements. So then from the side, we look to see is the femur forward. So in this case, their right side, we're looking from their left side. The right side is actually projecting forward, so their femur is in fact longer. Are we okay with that? So tibia, we're looking head on towards the head, and for the femur length, we're looking from the side. Believe it or not, this is a video clip. So this is showing being able to stand on one leg, and I'll define this in a minute. So with the proprioception, so we need to know what happens if they are able to stand and balance on one leg. Are they able to do that? Normally, we should be able to do that for 1 minute. We do it 2 legs, 1 leg. You can progress, eyes open, eyes closed. Please understand that if there has been a total hip replacement, hip dislocation, hip osteoarthritis, you may have lost, the individual may have lost proprioception, and then part of our treatment will be to retrain the knee and the foot to compensate. If the acetabular ligament is no longer intact, it is your main proprioceptor of your hip. So the cruciates in the knee and in the subtalar joint need to be taught to compensate. So this is really, really important, because one of the things you're going to find with the elderly is fear of falling is huge. And the fear of falling is often due to altered balance and proprioception. We are going to look at gait. We're going to look at, are they toeing in? Are they toeing out? Is there a flick? What's happening with the hip? We're going to be looking at the whole lower quadrant. So you see that children, as a child, they tend to toe in. As an adolescent, you were more, a child, you were more straight ahead. As an adult, you tend to toe out. An elderly, you go back to childhood and you start to toe in again. So it's important to know where in the gait, where in the gait cycle, where in the life cycle the patient is, so that you're not trying to create something abnormal for that individual in their gait pattern. We have talked about these last time. So intelligent gait, they're not going to want to take weight on that side, so they will shorten weight bearing on that side. They will shorten stride on the affected side. Especially with OA hip, they will try to decompress and get off that side as quickly as possible. Circumducted is one that's new, and circumducted simply means they swing. So they swing. It's often a stiff hip, and so they bring it in a circle to the front. So certainly this is one that, and it's pretty indicative of hip pathology, not specifically anything in particular. So Trendelenburg gait, there is no such thing. Okay? So this really should be called gluteus medius lurch. So why do we teach you Trendelenburg gait? Because that's what your clinician is going to call it. And you need to know what they're talking about. So Trendelenburg described the tests that we're going to learn. And then it was applied then to a gait pattern. And we said that it was like the penguin, where if they compensate, they will lean on the stance leg over the affected side. If they didn't compensate when they stood on the stance side and the pelvis dropped, can you see how they would be swinging and catching that foot on clearance? So in this case, a compensated gait pattern would be that they side bend over the stance leg to give the opposite leg clearance for swing. Okay, so the test. So when you ask them to stand on one leg, so this is uncompensated. Can you see that when they're standing on their right side, the left pelvis drops? It shouldn't. It should be able to stay level. The compensated test is when they take their weight on their left side to maintain that hip level. Do you see how they have to side bend over the stance leg? This is uncompensated. This is compensated. Are we okay with that? So it is the stance leg glute med weakness that is causing this problem. NWB, non-weight bearing. So this is an uncompensated, so you see the pelvis dropping on the non-weight bearing side, or you see them side bending over the stance leg to keep the pelvis level, to keep it from dropping. Are we okay with that one? Glute max, again, you're going to see this with hip problems, so not only with our spine problems, but our hip problems. So somebody who has atrophy of glute max will use their erector spinae to create the hip. So this is what we call a catch-up. So this is where every time the heel strike, you'll see them catching up using their spine to be able to create the movement. With hip problems, you're going to be dealing with a lot of individuals, all ages. So you need to know crutches, canes, quad canes, walkers. What are they using? And are they using it in the right hand? I told you one of my favorite things to do is to go to the mall and watch people walk. It's really good to have advice to be able to offer people, but my advice to you is make sure they really want to hear your advice. So my favorite was always, there was one lady who it was obvious it was her left hip, but she had the cane in her left hip. And so I said, oh, you know, I noticed that you, because she sat down, I said, oh, I noticed that you're having trouble with your hip, long time problem. I said, but I did notice that you had your cane, and if you put the cane in the right hand, it would actually help. It would take the weight off that side. My doctor told me to put the cane in my left hand. Oh, your doctor, I'm sure, was, but if you just tried it, you would see. And she started swinging the cane. My doctor told, I thought, well, that's good. Your doctor's right. I thought, no, it's gone. So there was no way. So, I mean, if that were my patient, I would have called the doctor and say, could you please tell your patient to, use the cane or listen to the physio and put the cane in the other hand. So I would work with, but since I didn't know this lady from a hole in the ground, I wasn't going to call her family physician. Thought she was going to assault me, so I moved on, found a new bench. All right. So leg length discrepancy. So the question is, if I have a leg length discrepancy, so can you see the pelvis is tilted to the right? So do we have a right short leg that is creating this apparent scoliosis? Or is this a structural scoliosis? How do I find out? What do I do here? So is this short leg causing a scoliosis, or is this structural? Okay, which foot will I put in under? Okay, so if I put something under the left, which one is the long leg, which is the short? Yeah, so if I go onto the right, then I'm trying to level this off. If this is related to leg length, what will happen to the scoliosis above? It corrects itself, all right? Which means this is something simple as putting a lift in the shoe. Yeah. Yeah. Oh, okay, I'm going to modify what you're saying. So what's being said is when you flex, what you're after is, what you will see is a rib hump or a rib flare on if somebody is structural. The problem is if you don't correct the foot, so the way you correct the foot is don't put something under their foot, sit them down, and now ask them to flex forward. If when they flex forward, you have a rib hump, and then you sit them down, and you get them to flex forward and the rib hump went away, the only thing that you changed was leg length. So yes, that tends to be a quick way, but there's a better way to make it more accurate, which is, does the rib hump still occur on flexion in sitting and standing? Does that make sense? If it's structural, you're going to have a rib hump no matter whether you are sitting or standing when you flex. But if it's due to a short leg, when you sit, now you're sitting on your pelvis, assuming your pelvis isn't short on one side, you won't have changed the structural scoliosis. So if all of a sudden the rib hump went away, the only thing you changed was leg length. Is that okay? So yes, that is done, and that was the one we looked at, active movements, why we looked for that smooth unwinding and we look for that rib hump. But again, that will still be present if you don't level off the pelvis. And again, it doesn't have to be structural. So scoliosis, so this is actually a structural problem. This is a scoliosis. This is a double curve, and there is also a short leg. So this is one where you might gain back a degree or two lessening the curve by putting a small, when I say a lift in, if I'm 1 inch short or 2 centimeters short in a leg, you never correct for the full loss. So you don't put in a lift for 2 centimeters. You put in for half, and you tell them to wear it for like 15 to 20 minutes, and then the next day for an hour, then the next day for 2 hours, the next day for 3 hours, you will find they have all sorts of new aches and pains by correcting even 50% of that list. Because this individual, this is not a new problem. This is structural, they've had it all their life, or since childhood, adolescence. Okay? Weight bearing, the easiest way, and this is often with our hip back problems, they're not, you say stand equally, and they're saying I am. And you're like, but you're not. But I am. Okay, do I look like I'm standing evenly right now? Where's my weight? Yeah, so I'm all on the right. Okay, you're not going to convince them. 2 scales, one under each foot. You know, one's got this much weight, one's got that. Are those numbers equal? Can you make them equal? Oh, and all of a sudden, then part of the problem is their loss of perception of body weight. They don't realize they're doing it. So we need to make them aware of that. So I do it with 2 scales side by side and try and get them to match and balance. The other thing with hips, get them to walk on the spot and stop. Either they'll stand with their feet together, which makes them unsteady, or they get into a sumo stance and you're like, you don't need that big of a stance. So just normal walking. Shall we go into the labs and get started?